Hello, my name is Béatrice Bouchard, and I'm a PGY4 urology resident at the University of Montreal, situated, as the name suggests, in Montreal, Quebec, Canada. Thank you all for attending this presentation. My presentation is on the research that I have conducted together with a team of urologists at the University of Sherbrooke, which is also in Quebec, Canada, on the topic of transcutaneous tibial nerve stimulation for idiopathic underactive bladder. As a preliminary remark, I wish to confirm that we have no conflict disclosures. The underactive bladder, or UAB, is relatively common. However, it's difficult to diagnose. It's a pathology which many physicians are unfamiliar with, hence the challenge in diagnosing and treating it. A very simplistic definition of UAB is voiding with or without storage LUTs that are associated with Detrusor underactivity. Obviously, patients with UAB are susceptible to many complications such as urinary tract infections, upper urinary tract deterioration, or even renal failure, and not to mention the detrimental impact that it can have on their quality of life. In addition to the challenge of diagnosing iUAB, when it comes to treatment, as physicians, we don't have much to offer to our patients. To date, the only surgical approach that has been FDA approved for iUAB without bladder outlet obstruction is sacral nerve neuromodulation, or SNM. Depending on the country, there's a three-step procedure to ensure the likelihood of effective treatment with SNM. The first step is what we call peripheral nerve evaluation, or PNE. It involves placing temporary electrodes in the sacral foramen and testing their effectiveness. If this proves to be successful, then the patient can move to the second and third step. As you may gather, this three-step procedure is costly and invasive and greatly limits patient accessibility. This brings me to what is known as TTNS, which stands for Transcutaneous Tibial Nerve Stimulation. It involves placing two surface adhesive electrodes a few centimeters above and below the medial malleoli. As you can see, this placement is not particularly invasive, and the treatment, compared to similar applications, is shown to have very few side effects. Studies using TTNS have proven its efficacy in fecal incontinence and overactive bladder. However, no human trials have been reported on its effectiveness for UAB. This is why our team at the University of Sherbrooke decided to explore the feasibility of TTNS in the treatment of idiopathic underactive bladder. The secondary endpoint of our study was to compare the effectiveness of TTNS with PNE in the hopes of better selecting patients for SNM. In our study, we selected patients with a clinical and urodynamic diagnosis of iUAB without BOO who were on the waiting list for SNM. The patients underwent a 3-week TTNS treatment. During week 1, patients had 1-hour-long sessions every day. The duration of sessions was increased from 1 hour to 3 to 4 hours every day for weeks 2 and 3. After this 3-week trial, the patients were then offered the option of undergoing bilateral PNE. Patients completed avoiding diarrhea at baseline, week 1, and week 3. Patient satisfaction was evaluated with a validated scoring instrument, the Patient Global Impression of Improvement, or PGII. After 2 years, a total of 26 patients have been included in the study. The median age was 67 years old and the median bladder contractility index was 62. 20 of the participants were male. 22 patients completed their bladder diary. 10 reported an increase in the voiding volume per micturition with a median increase of 43 milliliters. 17 patients had an increase in their voiding frequency with a median increase of 2.9 voids per day. 6 patients had a decrease in the number of daily catheterizations. The median decrease was 2 catheterizations less every day. Finally, 12 patients had a decrease in their post-void residual volume, or PVR. The median decrease was 75 milliliters. In terms of success, TTNS was a success in 45% of the study participants, whereas PNE was a success in 75% of them. 39% of patients had success with both TTNS and PNE. 23% had a failure of both. 8% had a success with TTNS only, and 31% had a success with PNE only. With regards to the PGI-I, 14% of patients considered themselves as much improved, 38% reported that they were somewhat improved, and 48% reported no improvement. In conclusion, a good proportion of the study participants saw an improvement in all bladder diary parameters with TTNS. There is, however, a considerable range of variability of responses among patients. There are comparable results in slightly more than half of the participants when comparing TTNS and PNE. In others, PNE still appears to be more effective, possibly because of the continuous stimulation that they were having with PNE. Given the comparable results, this study shows us the possibility of TTNS as a potential tool to better select patients for SNM. In terms of the PGI-I, more than half of the participants had a subjective improvement, and some of them, while reporting an improvement on this questionnaire, were considered a failure by objective measures. This shows us the importance of measuring patient satisfaction as a surrogate for success. Although our study has its limitations, such as a small sample size, the absence of a control group, and the possibility for selection bias, it still shows us the potential effects that TTNS has on voiding symptoms for iUAB without BOO. This is, to our knowledge, the first study that compares TTNS to PNE as a screening process for the treatment of iUAB. We therefore strongly believe that further studies should be conducted in this direction to establish its clinical efficacy. Thank you everyone for listening, and I would be happy to answer any questions you may have on the platform.